today's presentation is very challenging. I'm talking about toddlers and children malnutrition. So when you talk about malnutrition, the first idea we have normally is undernourished kids. I'm stressing on undernourished kids, but malnutrition is completely different from this. So the WHO had definitions, what is malnutrition? Malnutrition is either deficiencies or excess or imbalanced taking of nutrients or micronutrients. So they are divided in three groups. We have undernutrition, we have micronutrients malnutrition, either it's normally deficiencies, but sometimes we have excess of micronutrients, and we have obesity and overweight. And everything is related nowadays, especially when you're talking about non-communicable diseases later on in life. So what's the burden of malnutrition? We have very, very big numbers. So it's not something we can pass through because we have practically 1.9 billion people, including me, which is overweight or obese. We have 462 million who are underweight, unfortunately. And the biggest problem is that in kids, we have 52 million kids which is wasted. We have 17 million stunted, and we have 41 million kids who is overweight or obese. And it's not just numbers, because this can lead to death. This can lead to very severe diseases. And we know that 45% of deaths before the age of 5 years is practically related to undernutrition. And unfortunately, it's only in some countries, only in low and middle income countries worldwide. The malnutrition, it's not just a kid who is sick. It's a big problem for the society, for the parents, for the kid, for the doctors, for the countries, and for the future of the country and of the kids. Yesterday, we were talking about having in the same time malnutrition, undernutrition, and obesity in the same countries. This is called by WHO the double burden of malnutrition, because we are having at the same time a big excess of nutrients and obesity in some kids, and some stunting kids and some wasting kids, and normally these consequences are going through lifetime. So when we talk about the double burden of malnutrition, it's having in the same countries, even in the very poorest countries like in India or in Africa, in some countries of Africa, we have a higher risk of wasting and stunting with an increasing obesity in the kids before the age of 5 years. Malnutrition, it's not that democratic. So in many countries, we have more obesity, and in other countries, we have, in the same time, more stunting kids and a little bit more obesity. The figures are here are already talked about them. We have the biggest double burden of malnutrition worldwide. Which is surprising, we are talking about toddlers malnutrition. And WHO and the United Nations declared since the 1st of April 2006, this decade, starting till the year 2025, this is the decade of nutrition. So we are in the middle of this decade. And the aim of all the companies worldwide, pharmaceutical companies, food companies, are to treat and to prevent especially this biggest burden worldwide, which is malnutrition. Let's go through some definitions. Undernutrition, we always talk about growth faltering, we talk about failure to thrive, but we have to be, we have to be a little more precise. So when we put the good definition, we have the good treatment and the good follow-up. We have 4 broad subforms of undernutrition. We have wasting. Wasting is as simple as thinness. The baby is thin. We have stunting. He's not tall, he's short. We have underweight. It's a problem of his weight relating to the age or to his height. We have micronutrient deficiencies, and we have the severe form of severe acute malnutrition. So, undernutrition. In the same kids, we can be wasted and stunted at the same time, which is very, very, very severe. And if we don't act on time, we can transform this form of acute thing, which is a little bit moderate, to severe and chronic form of malnutrition. And if we pass the age of 2 to 3 years, sometimes it's very late to act. So globally, stunting and wasting are responsible of 3 million deaths of kids annually worldwide. And like I said before, it's not a matter only of having more weight or more height, they are very vulnerable, kids are very vulnerable, and it's also a matter of development and neurodevelopment according to the nutrient requirements. What is wasting? WHO defines wasting as having more than 2 standard deviations below the mean of WHO growth standards. We have many studies, especially in the SBGAN studies and in the Lancet, that are talking about BMI for age. It's the same thing practically. And it's a very good indicator for malnutrition. Wasting is used especially in low and middle income countries. We are talking about the developed countries, high income countries, or thinnest. So the baby is just thin or underweight. So thinness and wasting are technically the same thing, used dependently on the countries. But it's a problem, and children can be wasted and can be in the same time stunted. I'll talk about stunting later on. The global prevalence of underweight is decreased, but it's not decreasing as much as we like to. And unfortunately, the most underweight kids are, like I said before, in less developed regions in the worldwide, like many studies coming from India. What are the risk factors of wasting and underweight? We heard Dr. Bassil talking about less food, yeah. In the studies in Lebanon treated the kids with normal health. So they were not wasted, they were not stunted. But I think with time, if we keep on doing the same thing, we have either with time obesity or stunted kids. So it's an indicator for food, and it's an indicator for many diseases, which is related to immunity, which is also related to good nutrition and good food. And we never forget talking about hospitalization and the biggest factor of wasting during hospital time. So there will be a big part a small part talking about the wasted kids during hospitalization. What are the consequences of wasting? Like I told you before, it's not just having less weight. We have a weakened immunity, so we have more severe infection, we have bigger development delays, we have chronic wasting can lead to stunting, and stunting is not just short, it's also short in the head, and we may have an increased risk of death. So when we have a severe acute wasting kid, we had to act rapidly. We have to act as quick as we can, so we can prevent complications, and sometimes we can prevent death. Let's talk a little bit about hospitalized kids. You cannot imagine how many kids have malnutrition prior and during hospitalization. Almost 1/5 kids have a chronic or acute malnutrition at hospitalization on admission. So it's general, it's common, and we don't think about it more often, unfortunately. But we should have two numbers to take as home messages. It's 65% of kids, they lose weight while hospitalization, even if they were well nourished and on admission. And 45% of kids lose more than 2% of their weight on admission. So they are really serious figures, and it's not just big gastroenterology diseases. We have many diseases, practically all diseases. So 1/5 kids, it can be gastrointestinal disease, can be oncology. If you look at oncology, it's not that big, the figure, it's only 13%, while you look in respiratory and neurologic, it's 30 and 31%. So each and every disease, even if it's otitis media with a prolonged hospitalization, we have a risk of wasting and malnutrition. The consequences, we have an impaired growth, we can have increased morbidity and increased mortality sometimes. Why? Because we have these consequences. Because we have lower protein synthesis and muscle strength. We have lower synthesis of neurotransmitters, activity, vigilance, and cognitive performance. We have a lower immunity as humoral and cellular immunity. We have a lower wound healing and a higher complications post-operative. We have a lower pulmonary function, so we have a higher risk of pulmonary infections. We have a lower cardiac, renal, and intestinal function, and especially we have lower hepatic metabolism of the drugs. So please think about it, because if the baby is malnourished, we have a longer stay in the hospital. If he's severely malnourished, we have 55% more staying at the hospital. So if he was supposed to stay 10 days, he'll stay up to 15, 16 days. And it's 45% if we have just an acute, mild, moderate malnutrition. We have always to think about it. And on admission, especially if we know that the baby is going to stay more than 2 to 3 days in the hospital, we have to make a complete screening, BMI for age, length, height for age, weight for age, nutritional intake, weight loss, and not weight gain during hospitalization. We should stress on the nurses that they have to weigh the kids practically 1 day each day or 1/2 days. And if the disease is very severe, we have to think about it too. So when we screen, we can have a closer monitoring, but just taking the energy intake from the nurses and the weight from the nurses, and we can think about supplementation so we can prevent stunting and malnutrition during hospitalization. Few words about stunting. What is stunting? WHO definition of stunting is short. So it's below the standard deviation below the mean of WHO growth standards charts. So the global prevalence of burden of stunting before the age of 5 years is slowly decreasing. It is decreasing, thank God, but it's slowly decreasing. It passes from 40% to 25% in 2002. But 80% of them are practically in 20 countries and 40% in India. Having short stature is not a big problem, yeah, but stunting is not having only just a short stature. It's about also having problems in neurodevelopment, in psychological abnormalities too. Like we always say, toddlers are not small adults. So they are growing very fast, and they have recommendation for growing. They have needs, and these needs are especially for the nervous system, like myelinization, like formation of synapses. And mental capacity is developed, the most important development is before the age of 2 to 5 years, especially the first 2 years of life. So stunting is just not having a short stature, it's also having many needs during the development. So we have more needs of zinc, iodine, vitamin A, C, iron, calcium, protein, and energy. And comparing to adults, we have very high figures per kilo and per day. I'll go rapidly on the risk factors for stunting. We have risk because of the mother before getting pregnant, short stature, eating, well-being, etc. We have prenatal factors during pregnancy. It's very important to work on this, and this work is not with pediatrician. It's with the society, the whole society, and the government, of course. And we have the postnatal factors, and here we are talking about food. We're talking about nutrition, the good nutrition. So calories restriction is the major problem, and like Dr. Bassam also said today, the biggest problem is they have the volume, a big volume of food without having the good contents in this volume of food. We don't have enough protein, we don't have enough energy for growing. Okay, this is all optimistic? No, because we can reverse stunting. We can do it if we act on time. So never have a decision to wait and see situation. It's very easy to take as decision to wait and see in our clinic because we are very busy, because we have very severe cases, because we have rounds to take, because everything. But when we see a kid which is wasting or stunting, we should never wait on this. We should act. And prevention is a little bit complicated, but it's done. It's worked. We have many studies showing that it can be reversible, but if we work on time. So we have always to have this catch-up growth thing in our head. As a gastroenterologist, I only think about catch-up growth when I see a baby which is not growing as good as it was supposed to, I'll always think about catching up, and not only catching up on his body, on his thinness, on his shortness. It's also catching up on his brain, on his capacity, on his neurodevelopment later on in life. So a good balanced approach has to be taken not only to prevent, to cure stunting or wasting, but also to prevent going overweight and obese. And we can pass quickly from stunting to obese kids. He'll be a short, fat kid. This is not to do. We have to work on team. We have to work with nutritionists. We have to work with the gastroenterologist, so we can have a healthy, growing baby, either in his neurodevelopment, as in his state, his height, his weight, and his calorie intake. Interventions practically are on nutrition. Like we always stress, like Dr. Johan stressed yesterday, like Dr. Bassam stressed today, we have to work on nutrition. The good nutrition is the key for a balanced life. And if we do what we have to do, there's a question yesterday, if we do, how can we see if it's secondary or primary? We act on nutrition first, and if it's not going like we like to, then we go through diseases, we go through some problems, we go for investigation. But if we see a baby is not eating well, either energy or whatever he is eating, we start by treating his nutrition, which is the simplest, the cheapest, and the easiest way to work on. We treat his nutrition first. We prevent stunting, we prevent obesity, we prevent wasting. Then if it's not working with follow-up as good as we like to, then we thought about explorations, we thought about with blood tests, etc., to put the right diagnosis. And we have made multiple diagnoses, we can go through them. Just a little words about food behavior. Bassam, you talked a little bit too much about, a little bit very good about food behavior, but I'd like to add something. It's a big problem. It's not just a way of being, it's not a way of life. Because we are hearing nowadays, let him eat like he likes to, this is his way of living. It's not just so, it's just a way of living. Because it all started when we start giving food to the babies. We have two types of caregivers. Either you are infant-oriented caregiver or you are caregiver-oriented. Especially in our Eastern countries, especially in Lebanon, if the baby cries, we give him to eat. If the baby is annoyed, we give him to eat. Because we are responding to him, either it's emotional, physical, or hungry. If he's hungry, the only response we can give him is to eat, so he can calm down. It's not good because with time, we are creating changes in the behavior, nutrition behavior of the kids. Also, we have also the indulgent behavior and the restrictive behavior. Please finish your ice cream. Don't eat fat, don't eat burgers, don't eat this, and these two are bad to take because it leads easier to obesity later on in life. And the best way to teach kids how to eat is to teach the caregivers how to eat, because the model of the kid is his parents or the caregiver. So if we teach our caregivers how to eat, how not to snack, how not to eat fat, how not to eat fried food, etc., this is the best way, because the kid, normally with time, he follows what the caregiver gives. Let's take a little bit closer look. We are talking about 50% of the kids. They have very bad behavior eating. And the behavior eating with time, it's lasting at up to the age of 4 or 5 years, and sometimes up to the age of 9 years. So they have less protein and energy intake comparing to normal eating kids. We have less zinc, vitamin B6, and calcium, and we have a growth impairment in these kids. So it's one of the reasons why when we have time, we can have a growth impairment. And this growth impairment, it's not just during the 2 to 3 first years of life, it can go up to 4 and 5 years of age also. And the biggest problem, like I said, it's not just a body size, it's also a cognitive and development matter. So the eating behavior, when it's bad, we have lower cognitive development in kids. And we can, like I said before, we can prevent it. We can treat it we have to make supplementation necessary because we can have what we call a catch-up growth. Please, if you want to take one message from all this presentation, never wait and see. Always think about acting. Always think about having the catch-up growth as quick as you can, as early as you can, because if we pass the age of 2 to 3 years, sometimes we can be a little bit late. Some small guidance for the parents. We have to put the baby in a calm environment so he can eat calmly, not with iPads, not with screens, not with noises, not on the balcony, just in the space made for this. We have to avoid excess of praise, criticism for the baby. We have to avoid snacking and just put 3 to 4 hours before each meal. Don't give more than 15 minutes if the baby is refusing. Maximum 20 to 30 minutes per meal. You have always to use age-appropriate food. So pureed, then lumpy food, then self-leading food. And you have to try 15 or more times before saying the baby is not liking bananas, or is not liking apples, etc. So you have to use it more and more, try it more and more. We have always to encourage independent feeding, and a little bit of messiness is very nice. So we have to tolerate messiness, and not to be very stressful on the proper environment of the baby. As conclusions, never wait and see, like I told you before. Always aim for the catch-up growth thing. Prevention is way better than treatment in all deficiencies, either food deficiency, micronutrient deficiency, macro or micronutrient deficiencies. The matter of nutrition for toddlers are to be taken very seriously. It's not about the body, it's always about the brain with the body. And prevention will give us a better physical, psychological, social, and development future, and we can have better future countries with better future kids.